very quickly through the diagnosis of COVID. And as you can see from this template here, we will be using multiple modalities. But first, the clinical. As you know, the symptoms of COVID keep increasing every day. And most people are familiar with the fact that people might have fever, cough, dyspnea, and headache. But we now know that loss of smell or exaggerated Okay, there is a lag period of about 5 days, shown here as -5, during which a patient who is exposed to the virus could be asymptomatic before symptoms occur, symptoms I previously just described. However, the people who don't have any symptom during that period, some of them would never develop symptoms, and those are the ones called asymptomatic. But it's becoming increasingly recognized now that there is this group called pre-symptomatic group that would develop symptoms of some sort, even though mild or severe, at a later time. Let me go to the next slide. And here is the virology and serological diagnosis of this condition. And as you could see from here, this big curve here relates to the PCR, the antigen of the COVID. And the levels start becoming more and more detectable as time goes by. But note that at the time of presentation on day 0, there could really still be people who do not have a positive antigen and then becomes positive later. The immunoglobulin M is the first immunoglobulin that becomes available, and that starts about 5 days or so after onset, 3 to 5 days. And this could disappear within 2 weeks. And during that interval, the more we thought more permanent immunoglobulin IgG develops. Well, the studies from Oxford have now shown us that what we thought would be permanent is not really permanent, and a lot of these IgG antibodies are undetectable after about 2 months in a lot of people, even sooner in those who have who are asymptomatic or have mild illness. So this slide helps explain how clinicians could use the combination of PCR antigen antibodies to triage their patients. I'm not talking about the accuracy of any of these tests yet. Let's just assume that the tests mean what they are supposed to mean, meaning that they are very accurate. It is easy to see here that if you see a patient who has antigen and either of the antibodies, it is safe to say that that person has probably been exposed to their index event at some point a week earlier or slightly longer than a week. But as time goes on, the antigen levels may actually be undetectable, and immunoglobulins of IgG and IgM may be detectable, which means that those people may be at the convalescent phase, and likely those are the people who might really not be as infected. But I want to quickly summarize this review that came from Mayo Clinic, where they actually looked at all of the published data so far, or until April of this year, on the diagnostic performance of the PCR test. And the reason I bring this up is that apart from the inaccuracies that could come from not obtaining the samples correctly, this PCR technique itself is intrinsically not perfect. So they use modeling to generate this probability of a false negative test. And I'll take you through this. So day 0 is the day of exposure. And obviously, the probability of having the PCR is obviously a negative PCR. The probability of a negative PCR on the day of exposure is 100%. But look at this number I highlighted here. 38% of these patients could have a negative PCR on the day their symptoms begin. And if you remember, I said that the IgG-IgM starts forming around 5 days after the symptoms develop. But even at that time, that this about 8 days, the the PCR would still be negative in about 20% of those patients. Now, as time goes by, more and more patients would develop negative tests, such that at the end of 3 weeks, about 66% or 2/3 would be negative for the PCR 3 weeks after exposure. Obviously, those are not false negative. They are just negative because the virus has been cleared from the system. In the interest of time, let me just move forward to the next. And what this means in essence, therefore, is that if a patient has symptoms, has probable cause to have COVID, do not send them home or neglect to follow them because the PCR or your antigen antibody tests show that the patient is negative, because those tests do not say you could confidently dismiss those symptoms as if they did not originate from COVID. Obviously, there has to be a system of triage where such people are followed over time. Now, there are additional modalities which clinicians could employ. So if I need to know if this patient who has a cough, who may or may not have a positive antigen test, has COVID, well, I can get a CT of the chest. But if that is not available, ultrasound of the chest is actually very sensitive, and it does not specifically identify that the patient has COVID. But if somebody has symptoms of COVID and has ultrasound or CT scanning that is suggestive of the pathology of COVID, then it stands to chance that such a person does have COVID. What would you say? So to do the ultrasound, which is available in most places, just requires the expertise to be able to do them, but it's a teachable skill. You divide the chest, each half of the chest, into 6 segments. So if you draw a line above the nipple and a line around the costal margin, then you can have the segment on top being segment 1, the one below close to the midline being segment 2. And then this line would represent the anterior axillary line. So the top segment in the axilla would be the segment 3, the lower one will be segment 4, and then if you go to the patient's back, the space between the 2 scapulae on either side would give you the segment 5, and the large area of the base of the lung would be segment 6. And a very quick scanning of these by someone who knows what to do, would show the pathology on ultrasound that would suggest the subpleural damage and consolidation in the absence of effusion, which is how the changes are described. So I need to just show you this. Sorry. This is where the ultrasound probe is, and this shadow here, for those who are familiar with ultrasound, is just what the image shows. So this is the top of the skin here, and this is projecting through the lungs. Now, there are lines, these horizontal lines here, they are actually artifacts because the lung does not transmit ultrasound, but the pleura, both parietal and visceral pleura, they reflect ultrasound. So when the sound passes through them, the void of an empty, well-aerated lungs now creates shadows called reverberations, and those are called A-lines. This is what you would get if the lungs have air. You won't get those if the lung is full of fluid or has become, or the interstitium is damaged. And there is this shadow here that is more vertical, and those are called B lines. And they really reflect the passage of ultrasound through the interstitium. And everybody has interstitium, so it is possible to have a few B lines in a normal study. But this is what they look like when it's normal. Note that this line above, which is really what is creating these other shadows here, is moving side to side. So that's what we call the sliding of the pleura, and it is caused by the sliding of the parietal against the sliding of the visceral pleura as the lung moves against the stationary parietal pleura. And there's only one B line here that is just moving back and forth, and this represents a normal person. Now, there are other things that can cause B lines. So you have anything that results in the fluid going into the interstitium. So heart failure, infections that cause damage to the lung tissue and cause aggregation of fluid or inflammatory exudates in between the lobules of the alveoli would cause B lines. So then interstitial fibrosis or even injury, and of course ARDS. Now, show you some examples of abnormal pathology. So I'm showing this here, the panel on the left, to show you what normal looks like. Again, you see the horizontal lines, which are the A lines, okay? And then the vertical line moving like a searchlight, those are the B lines. And there's one or two in one field. Here is an abnormal one where you now have the B lines look thicker, and as they pass through the tissue side to side, they obliterate the A lines. So this person has a mild illness. And you can see the pleural line is a little thicker, but there is no break. So there is a little bit of increased fluid in the interstitium in this person, but the subpleural damage has not yet become serious. Here is an example of a more serious one. Now you can see that this area is now broken, and it looks like a waterfall of B line coming through. And I don't know if the contrast is good. This area of the pleura is no longer moving, so the sliding is absent. And you can see this dark area is actually consolidated lung tissue. So we can see consolidation, we can see early signs of pneumonia where the pleura are just thickened and inflamed and damaged. And this plays into the specific role of COVID, because the lesions in COVID-19 are peripherally distributed, which means they are within the reach of our ultrasound probe very easily. And they are bilateral, and they showed various degrees of abnormality. So this is what I'm demonstrating here. This is a more serious patient who now has this subpleural consolidation that you can see as a white area here, and you cannot see any B lines behind them. Oh, sorry, don't know where I am. You can't see any B lines. I don't know what is happening to this. It's going too fast. Don't show in this thing. So if I play this, aha, and then you could see there are actually broad B-line that are coalesced. They are not easily seen. There's still this area that you can see one, but these areas are actually a lot of B-lines that are fused. So that's ultrasound diagnosis. Now, chest X-ray can obviously be used, and you can see again that will show areas, traction, consolidation, and consolidation, and air bronchograms on X-ray. But CT scan is also very sensitive just because it can cover a large areas of the lungs. And the early signs on CT scan is that these are rounded, very small, and they look like small balls. They are fluffy, and that's what's called the ground glass opacities. And then there are areas where, because of the interlobular thickening, the type of thing that picks up, that shows up as B lines on the ultrasound, and it carves up the lung tissue looking like interlock, and that's what's called the crazy pavement pattern. And you could now see other areas of consolidation. And again, the characteristic appearance for COVID is that they have to be bilateral, they have to be, most of the lesions have to be subpleural, and there usually is no pleural effusion associated with the classic COVID pattern. So I have talked briefly about the clinical diagnosis, the virological and serological diagnosis, and the imaging diagnosis of COVID. The next presentation, which I would be giving in the interest of time, how we face some challenges unexpected in these patients that have COVID. And I'm going to present a 60-year-old man who came to us after a 7-day history of fever, body aches, and loss of appetite. And he had just become progressively breathless. And as we find out, many of these patients, they deny their breathlessness until it's really serious. So they always tell us, I just became breathless. But when we see their data, we have reasons to believe that that's not as accurate as they say. This patient has premorbid illness that include hypertension, gout, and hypothyroidism, and was being adequately treated for those. On examination, he was lethargic, confused, and just listless. And blood pressure was okay, but we noticed this bradycardia, and as you will see, that becomes significant later on. He was very tachypnic, and on room air, saturation was just barely 91, which obviously meets the criteria for hospital observation. On doing the labs, which helps us stratify the intensity of their inflammatory and cytokine response, we found this man already had serious markers of inflammation. Ferritin was 25,000. The upper limit of normal is 310. And the D-dimer was 5.1. Upper limit of normal is less than 0.5. Now, the other tests just showed mild azotemia. His chest X-ray, however, showed a lot of gram-glass opacification in both lungs, with air bronchograms visible in some of these places here. Heart was at the upper limit of normal. And here is his CT scan, which, as I will pause it if I get to where, which is showing you this peripheral distribution, things that look like spider webs. And at the lower zones, you can see there's a lot of consolidation in the lower zones. So if I let that play again. If I let that play again, you would see. So in the periphery, a lot of the small round opacities, and then the lower zones are really damaged. And although he says he was mildly breathless, you could see a lot of extensive damage had happened before he reached us. This is his lung ultrasound. And again, no A lines. And we did this in all the different zones. And most of the zones had abnormalities, especially the back. Now, the advantage of ultrasound is that if the abnormality is extensive, one could actually get away with just laying the patient face down so that you actually can protect yourself from the patient's coughing and just scan the back. Since bulk of the lesions are going to be in the back, for screening purposes, looking just at the back to find this type of abnormality in someone who has a likelihood to have it can cinch the diagnosis. So the broad confluent and absence of A lines. Now, this patient had bradycardia, and right away we saw that he had first degree AV block, and he also had these very diffuse T-wave abnormalities. And this would ordinarily be subtle, and there are multiple differential diagnoses for them. But in this case, we suspected that there might be something wrong with the heart. So we placed this patient on our cardiac monitor. And this is the initial ECG. Then the patient started complaining later of chest pain, and we repeated the ECG. Here is his echocardiogram. And for those who are not familiar with looking at echo, this is the 4-chamber view. Let me make the pointer show. Laser pointer. So this is the 4-chamber view. And you could see this area is not moving. So there is one motion abnormality there. This is using our speckle tracking, which is a very sophisticated way of looking at what the eye cannot discern in terms of regional wall motion. And this is called a bullseye picture. And this whole round area should have this color. This lighter color here indicates that the contractility of those segments are abnormal. So cardiologists will see this and say that there is abnormality in the left anterior descending and abnormalities in the right coronary artery territory, just leaving the left circumflex territory, which is this area, as normal. And it fits with this thing that you see here now. His troponin, which was done, now showed that he had elevated troponin. The upper limit of normal is 0.5, and he has 0.95. Although this is not markedly abnormal, but it does show myocardial injury. So we couldn't dismiss the bradycardia. So, like I said, he developed chest pain and his temperature started spiking and his white count started going up and his CRP started going up and troponin, while we were monitoring, increased several fold, about 4 times to 3.84. And when we repeated his ECG, now we see subtle abnormalities again, but of a different kind. Because the voltages are low, which again might actually be because of the pathology he has, we saw this appearance of tombstones. So instead of just having T-wave inversion, you have that flat tombstones, although they did not, the magnitude did not reach the magnitude that would make us consider this man for thrombolytics or acute immediate revascularization. These are what we call dynamic ECG changes because of the fact that we saw an earlier one looking slightly different, and we have troponin. So this man did have something going on with the heart. Was it something related to his history of hypertension, or is this related to COVID? That's what hopefully we would answer at the end of this. So this was when the troponin went up again. And I use this slide to illustrate how cardiologists now look at myocardial injury. So not all troponins are caused by blocked heart arteries. So we now have about 5 types of myocardial infarction. So I illustrate the type 1 and type 2 here. So type 1 is the classic one where a plaque rupture and blood clot occludes the coronary artery and creates obstruction which causes heart damage. That's probably not what is going on here. Type 2 is the type that happens when there is a mismatch between demand and supply, either because the patient has high fast heart rate, increased oxygen demand, hypoxia, spasm, and things like that. So, but there is no occluded coronary, but the wall motions are there. And as a matter of fact, these people have prognosis that is often worse than the people who have occluded arteries, just because the treatment of type 2 MI depends on what caused it, and some of those things are not as treatable as just going to put a stent in a blocked artery. So eventually, when this patient settled, we performed coronary angiogram, and surprise, surprise, this is the shadow of his left anterior descending, completely normal. This is the shadow of his very big and dominant RCA, which was normal, and the left circumflex, which is there in the back, which is a little smaller than the other two. So this man did not have occlusive coronary disease. And so we retroactively concluded that all those changes, the troponin, the wall motion abnormality, were all because of a type 2 myocardial infarction. It is still myocardial infarction rather than just a generic myocardial injury, because we had ECG changes and there was wall motion abnormality, which showed objective evidence of cardiac damage. Here is the paper again that looked at multiple published data showing different levels of severity of COVID. And as you can see, as you move from left to right, the patients who have severe COVID, most of them, 100%, have some heart involvement. As a matter of fact, there is a recent paper that just came out from the hematology literature talking about the people who got discharged early and the people with mild disease. And they are showing that about a third of those people actually have heart involvement, even the people who are not sick enough to get hospitalized. So let me skip this. This is just how they do the triage of myocardial injury and determine which is type 1 and type 2 and which is just the other non-ischemic injury. But here is the punchline here. Our patient had troponin levels on arrival that was higher than this, had 0.9. And you can see the mortality in the cohort of this when you collate all of the data is actually substantially high. Luckily, that didn't happen here. Now, the ability to measure small numbers like this don't exist in most places. These are what is called high sensitivity troponin, which is not available to most people. But we can detect, most labs can detect levels that start from this 0.5 and above. But you can see even small elevations that might be under the radar by our conventional data could be markers of myocardial injury. So the lessons learned from this is that we ought to check troponin level as a risk stratifier in patients who present with COVID, especially those who appear to have more mild illness, because that could help plan and hopefully reduce the risk of complications from myocardial dysfunction that many of these patients have. So I'm going to stop here. And again, because we have used a lot of time, I'm going to get Dr. Amina to come and present the second case. Dr. Amina is one of our medical officers here, and he's going to present this very interesting case, again, that shows us some learning points.
Thank you, Prof. Good evening, everyone. So I'm going to be presenting a case of a 45-year-old man who presented with an 8-day history of sore throat and intermittent fever. 3 days later, he developed a cough, which was said to be dry, not associated with any chest pain, but he progressively got breathless. In addition to that, he had generalized body pains and hyposmia. So we did a rapid COVID test, and later on did a PCR test. Both were positive. The only significant medical history he had was hepatitis B, which was diagnosed some years ago. But at presentation, it was not on any medication for that. On examination, we found him to be very lethargic, dehydrated. It was tachypneic, it was tachycardic, and his blood pressure was elevated at 150/91. He was poorly saturating in room air, almost in the 70s, so we had to immediately commence him on supplemental oxygen via the non-rebreather mask at 10 liters per minute. Eventually able to achieve a saturation of 94%. So we did an arterial blood gas at the time on an FiO2 of 90%, and we found his PaO2 FiO2 ratio to be 76. And as we all know, that meets the criteria for diagnosing acute respiratory distress syndrome. The other investigations we did showed very elevated inflammatory markers. As you can see, his CRP was 417, with the lower limit, or the upper limit being less than 5. Ferritin was also markedly elevated. His D-dimer was high to 3.57, with the upper limit being less than 0.5. He also had moderate impairment of renal function. His EGFR was 40. But interestingly, white cell count, his platelet count, all the differentials were normal. And as I've heard, the white cell counts, especially the lymphocyte counts in a lot of COVID patients, were always low, but in his own case, everything was normal. So we did a blood glucose at presentation, and as you can see, markedly elevated at 416 milligrams per deciliter. We went on to do an HbA1c, which was also elevated. His liver function was markedly deranged, showing a mixed pattern of hepatocellular and cholestatic picture. His bilirubin, the total was normal, the conjugated just mildly elevated, the upper limit 0.5. Here is the imaging investigations. I'd let that play so you can see the extensive nature, as Prof already spoke about, and as we all know about really the ground glass opacifications bilaterally in and you can also see the bilateral basal consolidations with airborne. And as we would appreciate also, there is no pleural effusion, which is very common in people that are infected with the virus. This is the chest x-ray, which just correlates with the chest CT scan. I mean, we can appreciate the extensive nature of is the pulmonary involvement in this case. So we was to start methylprednisolone. Some of us will know there's a new study done from UK that shows the benefits of dexamethasone in COVID-19 patients, those that have severe illness. And at the time we actually started this, the paper was but we did that on 4 premises on his clinical presentation. He had the hyperpyrexia, abnormal liver enzymes, the respiratory failure as was denoted by his arterial blood gas, and with all these, his white cell counts was still normal, as I stated earlier. So we started him on that, and his oxygen requirements were really high. So we did the non-rebreather, and that did not seem to work. So we put him on non-invasive ventilation via the continuous positive airway pressure. And it was put on intravenous insulin for glycemic control, ribavirin, lopinavir, and ritonavir to help with stopping or reducing the viral replication. We also started colchicine to modulate the immune response and the cytokine storm that we all know about. Supplements, vitamin C, D, zinc, and calcium, just to really help the immune system. So this slide really just, we can appreciate the cause of the inflammatory markers and the markers of liver dysfunction that was seen in this patient. So we can see from the peak levels that we got at presentation, we can see how that waned. We'll see that it didn't really reduce significantly few days into admission, but by the end and almost to discharge, the CRP especially was close to being normal, and even the liver function also was significantly better. So of course, this man continued to get better. He was progressively less breathless, needing less support, ventilatory support. So we eventually weaned him off the non-invasive ventilation. He was put on a regular face mask, and eventually even a nasal cannula, and he was saturating well. But on the 7th day of admission, something quite interesting and out of the box happened in this case. So I'm going to play this video. Okay, so I'm just going to let it play a bit so we can see the rhythm that we saw on cardiac telemetry. So a day prior to this incident, we noticed that his potassium level was slightly low, 3.4. Before all this happened, his electrolyte levels were fine. Even the derangements in renal function had already normalized. But this was something that nobody would really jump on, but we did actually still give him supplements and potassium supplements. So on this day, the morning labs showed that his potassium level had normalized 3.7. And the day progressed well. Suddenly he complained of some chest pain, which was vague and really was short-lived. We kept observing him, but he really did not have such a significant complaint. Some hours into the day, we just noticed began to desaturate and was now hemodynamically unstable, developed tachycardia, and then we saw this rhythm that is plain. And we made a diagnosis of Torsades Dupont, I hope I pronounced it, which is the polymorphic ventricular tachycardia. And we immediately gave him intravenous amiodarone, and also gave him intravenous magnesium sulfate, and it was eventually converted to sinus rhythm. So we took samples at the time, and it showed that his potassium was 3.3, which was a surprise because there was really nothing that would have warranted a continuous loss of potassium in that patient. We went on to correct the potassium then intravenously and continued with oral supplementation. And later did a coronary angiogram, which was normal, ruling out an ischemic component to this arrhythmia. Now, this slide just gives us a summary of the clinical course of the glycemic status of these patients. As I said earlier, the diagnosis of diabetes was a new one for him. And we will see that from the first day, the first graph just shows the maximum daily blood glucose levels that we got. And then the other graph shows us the required insulin as the days progressed. We'll see that it did get better, but really never went. So the maximum daily blood glucose was almost between 180 and 200 every day, and it was needing really high amounts of insulin, with reaching a peak of almost 80 international units. And this was, we would probably say, the IV methylprednisolone, which we know can cause some derangement in glucose, but we did
erudite presentation. So we will move on now. I'm talking about neurological complications.
So, good afternoon, everyone. I'm Dr. Emmanuel Mkano, and I will be running through the neurological manifestations of the coronavirus infection that we have dealt with at First Cardiology Consultants. I'll be following this outline, going through cases, doing a brief literature review, and then eventually settling on the lessons that we have learned. I also want to quickly say that all the patients that we've seen, of course, got definitively diagnosed with a PCR. I'll not mention that in our presentation to save time. First patient I'll be presenting, 67-year-old gentleman who presented with headache and fever of 5 days duration. Quite interestingly, he had been initially admitted and then discharged at another hospital. He was discharged at a point where his symptoms had completely resolved. 2 days after complete resolution of his symptoms, he presented with new neurological symptoms: slurred speech, diplopia and blurred vision, difficulty swallowing, weakness of all his limbs, worse on the legs, and then a lower motor neuron cranial nerve 7 palsy on the left. His comorbidities were hypertension and diabetes. Of course, to exclude the possibility of an intracranial event, we did an MRI, which excluded a hemorrhagic or ischemic lesion in the brain. We did a cervical spine MRI also, which excluded any myelitis at the level of the spinal cord and also excluded spinal cord compression or nerve root compression at that level. The lumbar puncture showed features suggestive of cytoalbuminologic dissociation, suggesting the possibility of acute inflammatory demyelinating polyneuropathy. His full blood count was remarkable for cytosis. Liver function test showed a mild elevation of alanine transaminase and some elevation of gamma GT. He had normal albumin levels and a normal globulin fraction. As is obvious here, his inflammatory markers are not as abnormal as you would have expected them to be, probably because he came in when the acute fever and other symptoms they had resolved, and probably at a point where the inflammatory process was quietening down. So we made an assessment of an acute inflammatory polyneuropathy, because we got a neurology opinion on this also, and he was treated with intravenous methylprednisolone and intravenous immunoglobulin. Within a very short time, there was marked resolution of the symptoms he came with, and he was discharged home. Second patient I would like to present, a 34-year-old gentleman who presented with headaches, myalgia, fever, and diarrhea of 7 days duration. Quite interesting. When he came, he was quite stable as far as his respiratory and cardiovascular system were concerned. His comorbidities, diabetes. He had, even though he looked rather stable when he came in, he had very abnormal inflammatory markers as shown on the screen. His CRP more than 14 times the upper limit of normal. His D-dimer levels extremely elevated. Because of his comorbidities, because of the very abnormal inflammatory markers, and because his blood sugar values were abnormal, the previous slide, the previous presentation showed that elevated sugar values increase their risk for a bad outcome. We admitted the patient, and this turned out to be a very prudent decision. Expectedly, he was a bit anxious on being admitted and tried to argue out of our decision to admit him. On the second day of hospitalization, he became quite breathless and eventually required oxygen therapy. In fact, at some point, we were considering putting him on non-invasive ventilation. On the third day of admission, he became agitated, expressed despair, mentioned regrets, basically started doing things to put his house in order. And he did mention that he was considering taking his life. That same day, he tried to choke himself with one of our hospital bed sheets. Once that happened, we placed him on a suicide watch, got a psychiatric consultation, where a diagnosis of an acute stress disorder, of course, with a failed suicide attempt. He was placed on antidepressants and sedatives. And after this, as far as his mental state was concerned, he did quite well. He spent about 2 weeks on admission, during which his respiratory status improved, was able to wean him off oxygen. His mood improved, positive outlook to his treatment, and essentially he had insight that the decision that he made was a bit unnecessary. We did, however, make sure that by the time he was being discharged, we had an effective support system in place, and we advise the relatives to watch to ensure that he does not have any opportunity to harm himself. Third patient, an 86-year-old lady, was previously rather independent, normally communicative, who presented with a history over 5 days of anorexia, fever, cough, and confusion. She developed complete aphasia without any limb weakness. At times before she came, she had done a CT scan, which showed bilateral ground glass opacities. At the time she came in, though, she wasn't really, her respiratory status was relatively stable. She needed only very minimal oxygen support. So we did, of course, to try to rule out an acute cerebral event, we did a CT scan, which showed things that were not unusual: age-related cerebral cortical atrophy with chronic small vessel ischemic changes bilaterally, but no acute lesion to explain her presentation. Her inflammatory markers were markedly abnormal, as we see on the screen. We also made effort to look for other things that could cause a change in personality or behavior or mentation of a lady of that age. A thyroid function test was normal, serum vitamin B12 normal, calcium, magnesium fine, no evidence of urinary tract infection, no evidence of infection or bacterial infection in any other system. She was managed with an acute stroke protocol. Initially, we had to keep her off food, pass an NG tube, and before we discharged her, she appeared communicative, that is, understanding what we were telling her, even though not verbally communicative. Her relatives brought her back within 2 weeks of discharge, mentioning that at home she wasn't taking medication. She required a gastroscopy tube inserted for nutrition to avoid basically malnutrition, failure to thrive. We have feedback that her speech eventually recovered after a few weeks, and we intend, as a follow-up, to take out the G tube if it's no longer required. I'll quickly review some literature available on neurological manifestations of COVID. As the previous presenter mentioned, essentially the initial step in the COVID infection is the virus binding to the angiotensin converting enzyme 2 receptor, which is found on several cells within the nervous system and also in the vascular endothelium. It's the inflammation in the nervous system cells and also the vascular endothelium and hypercoagulability that basically is the underlying mechanism for most of these presentations. Fortuny et al. In the Journal of Alzheimer's Disease this year proposed a 3-stage classification of neuro-COVID from stage 1 to stage 3, where essentially stage 1 is the mildest presentation, where the virus binds to sensory cells in the nasal epithelium and the mouth. And these are patients who usually will manifest with anosmia or abnormal taste. As long as the inflammation is limited to those areas, most of them recover within a short period of time. Neuro-COVID stage 2 that he proposed occurs with patients who, because of the virus binding and inflammation of the vascular endothelium, these patients have infarcts involving large and small vessels within the brain. So these are patients who may manifest with hemiplegia, sensory abnormalities, retinal artery or vein thrombosis, cerebral sinus thrombosis. In this stage, he also included patients who, via vasculitic processes involving the cranial nerves and peripheral nerves, or via immunologic mechanisms, may have cranial or peripheral nerve lesions, which of course can manifest variously. The first patient that I described falls within this group. The last stage, most severe stage, neuro-COVID stage 3 that he proposed are patients who have a very aggressive cytokine storm at the level of the blood-brain barrier. These are patients in whom the permeability of the blood-brain barrier is increased, permitting inflammatory cells, cytokines, and even virus particles to get into the brain, cause neuronal cell death, cause cerebral edema. And these patients may manifest with confusion, delirium, psychiatric manifestations, loss of consciousness, seizures, or death. This is a paper that was published in Lancet Psychiatry, and which essentially came out from data that was harvested from a CoroNerve platform. Essentially a platform that was made available for physicians who are involved, who are likely to see neurological manifestations of COVID to register or inform of patients that came with either neurologic or psychiatric manifestations. So they published that they were able to see 125 patients who were either confirmed or thought to have COVID, confirmed if they had a PCR test showing positivity, probable or possible if they had very suggestive CT scan or X-ray abnormalities or possible exposure to COVID cases. And it's clear from the spread of data here that most of the patients that they saw had cerebrovascular events, most ischemic, a few hemorrhagic, some cerebrovasculitic. Fewer patients had altered mental status, either from encephalopathic or encephalitic processes. Some of these patients had overt psychiatric manifestations, similar to what one of our patients had. A few patients had peripheral disorders, peripheral or cranial nerve disorders, and then a few had other cases that didn't exactly fit into this classification. So what have we learned from these cases? It's very clear that neurological symptoms may precede respiratory symptoms in these patients. This is important, of course, in view of the necessity for healthcare providers to have a very high index of suspicion, necessary to protect ourselves and to also protect other patients who may attend our clinics or be admitted in the same ward unknowingly with these patients. we saw a case where neurologic symptoms of COVID occurred after initial manifestation of the disease. Our patient came down with a demyelinating polyneuropathy after apparent recovery from the febrile phase, so to say, of the infection. But we also have papers that mention patients having apparently recovered from respiratory or the fever that this infection. Of course, COVID can masquerade as stroke in some patients, and then we need to basically have a very, very broad, very, very high index of suspicion, as these patients may present with central and peripheral CNS signs that may present as our patient, or can also cause, in some cases, as papers describe, difficulty weaning after ventilating these patients because of respiratory muscle weaknesses. So thank you.
And this patient that epitomizes what the real critical care problems we face in these patients can be. And I'll take you to this very whirlwind journey so you can get a flavor. So we had this 65-year-old man with past history of hypertension. He had tested positive for COVID about 4 days prior, and he showed up in extreme respiratory distress. He had tachycardia, his blood pressure was normal, but his oxygen saturation in room air was 53%, and he was breathing at 46 times per minute. So we performed an arterial blood gas right away, and this after giving him 100% oxygen. His PaO2 could only go to 84, giving us a PF ratio of 84. And as was mentioned earlier, whenever this ratio, that's the ratio of the PaO2 to the FiO2, when that ratio falls below 150, that fulfills the definition of ARDS. Well, our oxygen, we try to reduce the oxygen saturation so that we prevent lung injury, but we didn't really succeed to stabilize these patients. An hour later, his PF ratio had dropped to 71 when we dropped the FiO2 to 80%. And so an hour later, we repeated this again, and this is what we got. Things had gotten really bad. So his PF ratio had now dropped to 48. This met the requirement for non-invasive ventilation, and he started right off the bat on that. So this is what the screen of the ventilator looked like with CPAP, with a peak end expiratory pressure of 5 and pressure support of 7. And we tried to use an FiO2 of 75, but as you can see, we could not get a PaO2 of 58% with this after 30 minutes. We carried on, and we increased the FiO2. Curiously, we now performed an ECG because we had this prime to look for heart problem in these patients. And we found this pattern of right bundle branch block with right ventricular strain. So as you can see, this is V1 here, and showing these tall complexes in V1 with the ST, the downsloping ST segment in the inferior, and that anteroseptal leads. Well, we finding or an old finding. So let me just go over this, because again, you now see there is an S wave in lead 1 and the T waves are inverted in lead 3. So you get my drift. S1, Q3, T3 pattern. So the only thing that's missing of those is the Q wave in lead 3. We found that 2 months prior to this time, he had almost completely normal ECG, and this was sent to us from the patient's doctors. Well, his chest X-ray looked really bad, and you can see the whole lung is white out, and only a few areas showed some aeration, and this is probably why we had such a severe hypoxemia. Again, looking at the vascular markers, he had high markers of inflammation, high markers of coagulable state. He was not anemic. Kidney function at that time was normal, but again, troponin was abnormal in someone who had no history of heart disease. He was treated with proning in addition to his CPAP ventilation, and proning is something that we find to be extremely useful in treating these patients. And the thinking is that because a larger surface of functional lungs is situated at the back, allowing patients to lie face down, expose those areas to greater advantage. He was given cortisone and vitamins as was previously discussed, and at that time we gave antivirals to prevent viral replication. Because of the S1QT33 and the fact that we saw this patient was not really doing well even with our CPAP machine and increasing the FiO2, and the X-ray that we saw and the D-dimer that was elevated, we had probable cause to suspect this is acute pulmonary embolism was playing a role, so we gave alteplase and temporarily got some improvement. Now, this is tracing his cytokine storm, and this is showing the progress of the CRP. So day one, he had that level that is about 180. By day 5, it had gone up to almost 300. And at this time, his procalcitonin levels were high, and he was commenced on intravenous broad spectrum antibiotics. He also developed leukocytosis. So this helped us to identify the diagnosis of cytokine storm, and he wasn't doing very well with his breathing. So we gave interleukin-6 blocker, the tocilizumab, to try and modulate this cytokine response. We also gave him convalescent plasma at this stage, and we repeated the blood gas. The blood gas was not getting better. So he was mechanically ventilated. And the type of ventilation that is recommended for COVID patient ARDS is what is called lung protective ventilation, whereby we dial in a low tidal volume, which is calculated as 4 to 6 ml per kilogram of the patient's dry weight, which is calculated based on his height. We also then set parameters or adjust parameters that can help us reduce the plateau pressure to a number that is less than 30. And that's what is called lung protective ventilation. And we can use a high ventilation rate and you change the PEEP as appropriate in order to allow us to do that. So we did this, and we did get some improvement from where we started. And this improvement continued for some time. And you could see from the CRP curve here that tocilizumab appeared to help us substantially. The CRP levels came down. However, other organs did not cooperate. His coagulation parameters continued to worsen, and his D-dimer increased. And kidney that was normal on arrival started showing us abnormality with the urea. So we now saw the worsening of renal failure. And this now necessitates the use of deployment of additional technology. So we started using vasopressors to increase renal perfusion, vasopressing, norepinephrine and epinephrine, and changing those levels appropriately to just manage heart rate, manage systemic vascular resistance. We gave hydration as necessary. This real cardiac critical care at this moment. We started giving inotropes to support the heart. And of course, over time, he did not improve the renal function, and we had to start him on continuous venous hemofiltration. This is what that looks like. And we basically slowly try to extract volume while we slowly remove the urea from his system. Now, his respiratory failure, as shown by carbon dioxide retention, is plotted here. So we started CPAP when it was at that level. We started intubation when it was at that level, and things improved a little, but because of all the problems start happening with the kidneys, we had to put him on extracorporeal membrane oxygenation. This is our ECMO team. It's a very technically demanding and labor-intensive team and service. And this is a rare service. There are only 15 beds available in a total of 5 centers in the United Kingdom. So this isn't something that is available anywhere to everybody, even in developed countries. So this is what this entails. So this is the machine. We basically create here an oxygenator that acts as an artificial lung. And we would take venous return blood from the inferior vena cava, put it through the oxygenator here where we have an oxygen exchange and a carbon dioxide exchange tool in there. And then we give the oxygenated blood back to the patient through the superior vena cava. So this is called veno-venous, because although this is arterial blood, it is still being pumped into the vein. This is what it now gives you. So you'll see this is this person's venous blood because of this ECMO. So venous blood actually has PaO2 that is higher than what average people might have, because that is the spent blood. So you can imagine, what does the arterial blood that comes out of the ECMO look like? We have PaO2 of 506 millimeters of mercury. And so, although this is coming through the venous side, it would basically overwhelm the capillaries on the other side, so that a lot of these would perfuse, just by a gradient, will go to the arterial side. So this is actually what the arterial side would see. And this is not done with a lot of contribution from the heart at all. And here is the triage for this. And we basically, you have to take patients who have failed all of the usual things that you need, including proning, including the use of ventilators that are adjusted as appropriate, the use of PEEP, and all the other modalities. So what did we learn from these patients? In totality, the basic conclusion that we can make here is that COVID care is very labor intensive and expensive. And the care involves a lot of disciplines of internal medicine, psychiatry, even surgery. But the emergencies can be adequately managed if we learn to preemptively monitor certain parameters. Thank you very much. So we will now, I don't know if somebody has been moderating the questions. We can take the questions now, and I would get all of the speakers to be able to answer the questions. Is there anybody who has been keeping tab of the questions?
Yes. So far, no question. I don't know. Maybe people want to actually ask questions. So if they've not sent any chat so far. So if you want to ask your questions, you can either raise your hands or send a chat.
Okay. So
okay, somebody is raising a hand here.
How do I do? Who is raising hand? Let me unmute that person.
Yes, you can.
Okay, hang on. Okay. Yeah. Okay. Go ahead.
Yes. Good evening, sir.
Good
I just
evening.
wanted to make a comment that the chat section is actually disabled, and that's why we couldn't put our questions in the chat.
Oh, I'm so sorry about that. We had technical problems. We had to restart many times. We had power outage. We had internet outage. Hazards of working in resource poor environment. But we're good.
Okay, so that was just my comment, sir. Thank you.
All right. So, yes, any question?
Okay, so there are two participants, Dr. Okunuga.
Okay, any questions? If the person raises hand, I have unmuted that person. Yeah. So you can speak, Dr. Okunuga.
Okay, good evening, sir.
Good evening.
Am I audible? Okay, thank you very, very much, sir. I would just like you to explain the RNA, the antibody pattern again from the first presentation. I didn't really get
Okay, what we said about that is that the apart from challenges with sample collection that can render the test less sensitive than what it is supposed to be, the profile of this disease is that the virus first gets into the body and the body tries to contain it, but it continues to replicate. And there is still a significant proportion, about 38% on day one of symptoms, which might be 5 days after exposure, where the test would be negative. But if you check those people again, it will be positive. And so the point I made is that do not base your decision on saying a person who has symptoms suggestive of COVID. Base the decision on saying they do not have COVID on the fact that the PCR the test came as negative. That is what the data is showing, that the clinical suspicion should still play a significant role. But I quickly went on to say that as clinicians, there are other things that we can do. So if I have that suspicion and the initial test is negative, we can do other tests. We can check the markers of inflammation. So if somebody who has no other reason to have a high CRP, has a high CRP, has a high ferritin, has a high D-dimer, then you really have to err on the side of caution. And then if you do CT scan of their chest and you see these classic lesions, especially the distribution, and you exclude the presence of other things like regular pneumonia, pulmonary embolism that is distinct, you could still, without these antigen positive tests, make a reasonable diagnosis of whether someone has COVID. But if you repeat the test, then one of two things would happen. Either the test would then become positive or the patient would develop antibodies. And that way you would be able to conclude that your initial assumption that they had COVID is correct. Okay, any other questions?
So Dr. Okpawoye, you can ask.
Okay.
No?
Okay, Dr. Okpawoye, yes. You can ask. Oh, okay. No, you have to unmute. You have to unmute yourself. Okay, you can unmute yourself. Where is it? Don't use your hand. Okay. Okay, we have. It's not unmuting. Maybe we'll go to someone, Dr.
Chisom.
Dr. Louis.
Okay, Dr. Tolui has been.
Dr. Power now.
Okay, thank you very much. Okay, Dr. Tolui.
Okay. Who is speaking?
Dr. Power is speaking. Is it still there? Okay, Dr. Tolui, I think. Is that you?
Yes, please.
Okay.
Thank you, Prof, and the other presenters for such a lovely presentation. You talked about giving antiviral. Which antiviral did you give? And you also mentioned to stop viral replication. By implication, that means there is now a proven drug that treats COVID. If we can say that to stop, it stopped viral replication. So I'd like to know which antiviral was given, and that is it confirmed that we now have an antiviral drug that stops replication of SARS-CoV-2?
Okay, well, this, as you can see from this presentation, we are learning as we go. But earlier on, there was this study from China and supported by another from South Korea that used the combination of the lopinavir, ritonavir, and ribavirin. That was a suggestion. Subsequently, the data was shown not to be very good, except to combine it with interferon 1, 2 beta. So the presentation we have made to you spans the period starting from February, and there are a lot of things that we now do. That a lot of things we did then that we don't do anymore based on the data. Now there is remdesivir, which there is data that shows that it reduces the rate, the positivity rate, which implies that it probably reduces the replication of the virus, and that's at least the data that we have. And the details are not really out in public domain yet. But the information we have on that at the moment is we did not have data that it prolonged life or that it shortened hospitalization. So there's still ongoing data that's combining remdesivir with other things. And I'm sure as time goes by and we learn more, we will change our practice. But as of this moment, the only antiviral that has some data, albeit data on replication rather than survival, is remdesivir. Okay. There are some questions on the chat. So let's take some chat questions. And there is one that, which one did you just show me?
So there are some questions on the chat.
Yes. So let's take some chat questions.
Okay. So one from Aisha Akinkube. Thank you for sharing your experience. So she said nothing was mentioned about outcome for the last patient presented by Professor Ogunyakin.
Well, patient is still on treatment, and the point of this discussion is not so that we can focus on an individual patient. It is so that we can show the diversity of the critical care decisions that have to be made. There are patients that are being treated and ongoing. So that's the reason we did not present outcome on all of the patients.
Okay, so I think we'll be commending FCC from Dr. Aderomu. Wonderful and eye-opening presentations. What is the survival rate in patients that eventually required ECMO?
Okay, so the data, again, this is data. This is a question that has a variable answer. As of February, when the first published experience on ECMO, were the study that came from China, they reported, I think, about 27 patients that they placed on ECMO, and only 6 survived. However, the Germans, through their consortium or European consortium, they have an ongoing registry where all the patients that are that meet the criteria for ECMO and are placed on ECMO are ongoing. As at the last report, which was at a webinar, they showed that they had recruited about 1,200 patients, of which about 500 had survived. And obviously, as you can see from the cascade that we showed, people get to the cascade of ECMO when all other things have failed. And that's actually why it is not a resource that is made available, even in America. It is not a resource that is made available to every region or district. It has to be centralized in a way. So I think we are still writing this story. Whether we would be able to ascribe the success rate of ECMO to ECMO alone, or ECMO and our improved understanding of how to treat these patients, including the use of dexamethasone that is going to be more widespread. We were early starters in the use of colchicine, and people are going to start using those better. And there may be, maybe we would have some combination of remdesivir and something else that improves survival. In the end, the people who go on ECMO, their prognosis will continue to improve. As of today, it is what you do when everything else has failed.
Okay, thank you, Prof.
So there is a question here that says, talk about immunothrombosis in COVID-19. What is your view on the use of thromboprophylaxis? Oh, well, yes, that is actually a significant omission from this presentation. But remember, the topic of this presentation is acute critical care. So we give all of these patients antithrombotics, low molecular weight heparin while they are very sick, and we have been sending them home even when they recover with novel oral anticoagulants because they are easier to use. That's based on the understanding that the most dominant pathology of COVID is blood clots. So it is an incredibly important treatment modality to give to the people. However, I caution people who do that not to do it without being able to monitor the patients, because COVID also predisposes people to excessive bleeding. And one of the banes of our existence in our ICU is that patients who seem to have problems with clotting suddenly start bleeding from everywhere. Now, there's a paper that I just saw from the hematology, what's the name, in England, that shows that the thrombotic risk appears proportional to the level, the intensity of the inflammatory markers, like the CRP that we are measuring, like the ferritin, and that the D-dimer is a very useful tool. How to use it to stratify risk is still what is not very clear. Somebody asked here about Dr. Joshua Dewumi, will long ultrasound scanning be useful in a situation where there is a lack of CT or CT absolute requirement? There are one or two publications that show that ultrasound has a higher sensitivity but you know, anything that has to do with technical ability, you have to take it with you have to know how to interpret that data. Yes, if long ultrasound were done in centers like ours that do quite a bit of it, they would probably they correlate very well, for example, with our CT scan, and we actually pick things that are the lesions that are very, very few before they become very obvious on CT scan. But because ultrasound scanning is operator dependent, if you are requesting those tests, you really have to be very careful not to just take a negative study done in any place, just like anything else, as negative. But CT scan does not really have the operator dependence, and it is faster. It's more expensive, but faster. But where you do not have CT scan, or when the patient is too sick to go for CT scan, if you can get long ultrasound, you will make very good decisions based on that. Somebody also asked, Effiong Elumelu, what's your opinion on the use of ivermectin for COVID? No opinion. I know that that's an anti-malaria. And when I see data, I would probably be able to see. I have not seen data that convinced me. Did your patients recover, I mean, presented here? Well, again, this is not the object of this presentation. Yes, we do have a lot of recovery, but that's not the subject of this. This is critical care, trying to show the what we see. So let's take some other hand-raising people. Opawaye is now back. Let's because he is one of the people working in the COVID center, and it will be important to hear his question. Okay, you can speak now, Lauren.
Thank you very much, Professor Obeake. Very wonderful presentations as usual. When I was seeing the pictures, like when you showed the ECMO team, they were in full hazmat suits. And so my question is, you know, based on the fact that generally people are turning more towards wearing just the surgical gowns and apron, is there any reason why you persisted with hazmat suit? I know the hazmat was worn initially at that time of break in China, when they were not sure what they were doing. That's one. Two is, what has been the experience of your staff? I don't know. Well, this kind of patients look like patients you have to stay with them 24/7. So, and some of these patients apparently spent quite a while in the hospital. And one of the problems we've had is in some isolation centers is staff complaining that they cannot stay with the patients because, and so the care of the patient suffers. So, the staff stay with
Okay, the line has gotten very I heard, let me answer the part of the question that I answered. Those are very, and obviously that is a question from who are involved with the practical aspect of taking care of these patients. Now, yes, our staff are in hazmat suits. The answer to that question actually answers the second part of your question. The patients with COVID are taken care of in our purpose remodeled center, where when the staff go in, they spend 6 hours as a team for a shift. So that's one of the things that make these very expensive to take care of critical care for COVID. Instead of having staff strength that would require, for every job you require just 2 people in 24 hours, you need 4, because the longest interval that staff can stay in those suits is 6 hours. That's what the South Koreans have shown to prevent harm to the staff. So it is very, very labor intensive. Now, we use the hazmat suit because while we might believe that somebody who is got a protected airway because we already have them on a ventilator and all that, might not generate aerosol, they are taken care of in the same unit where some patients who are on non-invasive CPAP, some of them need to be nebulized and things like that. So we rather chose to protect our staff, even though it's a much more expensive way to do so, than to take any chances that there would be exposure to COVID that will render our staff non-functional. And as you can imagine, if you already have a higher staff need, you cannot afford to lose anybody to illness. So that's really why we are doing that, and we are not planning to change that practice anytime soon, because the priority is on making sure that we protect the well-being of our staff. And the 6 hours is still the rule we are following. It just means that it costs a lot more to take care of these patients, and the cost of the suits alone, shift after shift, is enormous. Let me take another question here. Can COVID-19 patients retest positive after recovery? Yes, that's the simple answer to that. Why? Those the immunologists are still trying to unravel that. Part of it is because the one test may not be as accurate. The second part is that a lot of positive tests that come after 7 days are caused by non-replicating virus or non-replicating viral particles. They are not the type that are contagious. As a matter of fact, the Center for Disease Control just came out yesterday with a non-testing guideline that says that if somebody has spent 10 days from the onset of their symptoms and they feel well, you do not need to retest them. Even if they are still positive, if you do, they are not producing virus that can contaminate anybody and cause anybody illness. That is the guideline, and similar to what the WHO had done about 3 weeks ago. And so we know about those, but why some people test positive again, we don't know. But we have some experience in that too, and we're trying to understand it. Somebody already, Dorothy, is there a Nigeria-wide forum similar to these that will allow you and others to start weaving the Nigeria story, or a registry of some sort? Well, I suppose you can say this is one of such. Maybe this would lead to more and more that we will do in the future. Can lung damage occur in COVID-19 patients on ventilation? Yes, actually, yes. That is actually why the strategy for ventilation is this lung protective, where you do not use a lot of tidal volume, so you don't pop the few alveoli that are still working. And that is deliberately what you do. However, if you use the lung protective ventilation and the patient is not getting better, you're going to need to increase tidal volume and do whatever you could to buy yourself some time and help the patient recover. Did you have any COVID positive pediatric patients? Sorry, we are purely an adult center. Do not take care of pediatrics. Has there been any word on population healthy control studies for COVID testing to validate the reliability of any positive tests we obtain? Is it safe to believe now that African populations are protected from COVID, given the wide disparity between confirmed cases and mortality ratio when compared with Western countries? Well, I'm not sure what data you're referring to. I'm not sure that if we got our real data, this assumption that you have just made here is even accurate based on the data available here. So I think that's a political question. What single inflammatory marker will provide the best prognostic tool? Please do not use any single inflammatory marker. As a matter of fact, if you look at what we presented here today, you would see that there were people who had bad outcomes even when they had recovered their prognostic markers. There were people where the dangerous things happened to them before the markers became obvious. And there are sequelae of things that happen way after any stage. So just like anything in medicine, I think clinicians have to use the totality of all the evidence at their disposal, because no two patients would be alike. And I really feel that we should move away from trying to find one thing that is a game changer. I don't think it exists. Let's see if we can get some more questions let's get questions from people who are on the chat. Okay. I'm trying to unmute some people. So if I ask you to unmute, you should please unmute yourself. Okay. This is Dr. Tolu.
I don't have a question. Hello, I don't have a question right now. I kept getting the pop-up of unmute your mute, so I unmuted myself. I don't have a question. Thank you.
Okay, sorry about that. Okay.
Thank you.
Okay, so is there any other written question? I think, is there anybody else that, okay. Okay, thank you very much, everybody, for participating. Hopefully we'll get to do more of these at a later time. Mohammed, are you there?
Yes, I'm here.
Okay, is there anybody else that is asking any question?
I think we've exhausted all the questions. None from.
Okay, thank you very much for your for coordinating, and we apologize to all the listeners for the technical hiccups, but at least we got it done. The spirit in Nigeria is never to give up, even when things don't look good. Thank you, everybody. Okay.
A lot of kudos from different people.
Hmm?
A lot of kudos in the chat. Different things from different people in the chat.
Okay, I want to save this thing now, because you have to do that. And thank you, all of you did fantastic.